Erica Webster from Binghamton University, here to share with you some of my dissertation research focusing on the impact of adverse childhood experiences on health and development of young children. This research kind of builds on some of the early research from the 1990s on the way ACEs can kind of derail developmental trajectories and lead to all these really negative things like dysfunctional neurological development, social and emotional cognitive impairments, risky health behaviors, disease, and eventually early death, which is definitely a scary outcome. So I'm specifically looking at the impact of ACEs in early childhood because there's so much potential for neurological development. We can see the differences between a normal healthy brain that's had typical positive experiences in childhood compared to a brain that's experienced toxic stress or some of these adverse experiences. There's significant differences in the neurological connections. There's fewer connections in a brain that has experienced more stress and trauma. So this research is especially important for looking at the development of children and how there may be a connection between ACEs and disability and ACEs and just having a healthy life trajectory in general. I'm especially interested in those early couple of years because there's rapid brain development happening in those first few years of life. Before the age of 5 is kind of what I'm most interested in because I believe that this can change the developmental trajectory for some students. There is a decreased odds that they will need higher cost educational services, including special education down the road. This research is also really exciting for me as a mom. You see my 2 beautiful children, and I love this photo because there's some space in between them that I like to say represents the kids in my life that I'm not allowed to photograph as a foster mom. We have seen kind of firsthand the impact of ACEs and of positive parenting, kind of what can happen as families gain some resilience and gain some skills to turn things around. So I know this gets kind of a dense topic, and I want to elaborate on that there is hope and there's lots of room for growth, regardless of what kind of a baggage kids bring to the table. So the research questions I looked at specifically were, is there a difference between individual ACE exposure in predicting health and developmental problems? And then what predictive power does this cumulative ACE count have? And then my last question focuses on the role of affection with a parent or caregiver in kind of slowing that, like decreasing the odds of having issues down the road. So you can see my conceptual model. My first model, I looked at each of these ACEs broken down individually and looked at the impact on health and developmental outcomes for young children. My second model looked at kind of the number of ACEs, this cumulative count, and in addition, it considered the role of being affectionate with a parent on the overall health and developmental outcomes. So I have used a pre-existing data set from the National Survey for Children's Health. I used the 2016 cohort, and as you can see, there's a pretty good breakdown between males and females. The majority of the sample is white. There's a range of ages, and there were about 14,000 children overall that participated in this age range. So I had a pretty good data set to kind of work with. It gave me a lot of options, so I'm thankful for that. What are adverse childhood experiences? First, living in poverty, parental separation, the death of a parent, parental incarceration, witnessing domestic violence, witnessing or experiencing community violence, having a parent with a mental illness, having a drug or alcohol abuse in the home, or experiencing racial discrimination. So of these ACEs, the most common was that difficult to get by on current income, followed by a parental or guardian divorce or separation. The least common one was being treated unfairly because of his or her race. Again, we're looking at children under the age of 6. And majority of kids had 0 ACEs, which is also a really positive thing to see, with the fewest number of children having 4 or more ACEs. So it's kind of a good trend, but having 1.8% of children that have 4 or more ACEs is still too many. So what are special healthcare needs? What's my outcome? First is taking prescription medication, using more medical or educational services than other kids their age, being functionally limited in their daily activities, receiving special therapies like speech, occupational therapy, physical therapy, or having emotional, behavioral, educational differences. So looking at kind of the breakdown between what percentage of this 14,494 children had each of these special healthcare needs. You can see the most common is having a prescription medication, but looking at the difference between percentage of kids that had 0 ACEs and 2 ACEs, you see that almost doubles. It goes from 10% of children with 0 ACEs having one or special healthcare need to 24% with 2 or more ACEs. So those are some pretty significant differences, which kind of leads me to look at my first question. Is there a difference in between each of these individual ACEs in predicting these health and developmental outcomes? Yes, but not for each of them, only for difficulty to get by on income and living with anyone who's mentally ill, suicidal, or severely depressed. The other ones were not significant. My second question, what's the predictive power of these cumulative ACE count? And what we see is there's kind of a dose response. So for individuals with 1 ACE, they have a 68% odds of having a health or developmental problem. With children with 4 or more ACEs, that jumps to 137% odds of having health or developmental outcome. That's huge. My third question is looking at the role of affection. So overall, there was a 33% decrease in odds of having health or developmental issues down the road for children who were reported as being affectionate with a parent. This kind of shows how that gap changes over time. For kids with 0 ACEs, it was relatively close. Whereas kids with 4 or more ACEs, that seems to be a more widely different outcome. So that was kind of exciting news. We think ACEs are kind of unpredictable and put you on this negative trajectory, but it gives hope that what parents are doing does make an impact. So my key takeaway message is financial hardship and mental illness do significantly increase the risk of having health and developmental needs. Overall, there's this dose response relationship. The higher your ACE count, the higher the probability that you will have developmental needs. And children who are affectionate with their caregiver have decreased odds of having health and developmental difficulties. So this is hugely important because if we can use some of these strategies we know to be best practice teaching and best practice for our families and our communities in general, we can prevent the impact of ACEs. So strengthening our families economically, those social supports that we can put into place all make an impact. Teaching skills, social emotional learning, healthy relationship skills are also hugely important. And connecting kids with programs that make a difference can help change their trajectory, prevent future ACEs when this generation grows up and then has children of their own. And if we are able to reduce the prevalence of ACEs, there's anticipated to be a decrease in all these really negative health conditions, as well as a decrease in risky behaviors and decreased social economic challenges. So there's a lot of just collective good that can come of kind of preventing ACEs. So some notable limitations from my research is that I used cross-sectional data. So I have a snapshot in time of information regarding kids and their development. I would love to have longitudinal data that looks at ACEs, but that's kind of just not publicly available at this moment. And I also want to acknowledge that there are other protective factors that are really important besides just affection. So that is all for me. Thank you so much for your time.